alaikum. Bismillahirrahmanirrahim. Our lecture today about the postpartum hemorrhage. Definition of postpartum hemorrhage by the definition is divided into two types: primary postpartum hemorrhage, blood loss of 500 ml or more within 24 hours of delivery. That means first day of delivery. Secondary postpartum hemorrhage, significant blood loss between 24 hours and 6 weeks after birth till puerperium. Mean blood loss with vaginal delivery 500 cc and if more than 1000 cc is hemorrhagic. Mean blood loss with cesarean section 1000 cc, more than 1500 cc is hemorrhagic. Seen in all deliveries, about 5%. Why we do care for postpartum hemorrhage? In the developed countries, primary postpartum hemorrhage is the fourth major cause for maternal mortality after thromboembolic embolism, hypertensive amniotic fluid embolism. Major obstetric hemorrhage, more than 1000 ml, very rapidly lead to maternal death. Risk factor for postpartum hemorrhage: most cases have no risk factor. Previous postpartum hemorrhage, antepartum hemorrhage, grand multiparous, multiple pregnancy, twin pregnancy and more, polyhydramnion, increase in amniotic fluid, fibroid, uterine fibroid, placenta previa, prolonged labor by oxytocin induction. Prevention of postpartum hemorrhage: be aware of risk factor may present antenatally or intrapartum. If patient have any risk factor previously mentioned, we do for her preventive measure. Treated anemia antenatally if she had anemic. Some evidence support use of oxytocin after delivery of anterior shoulder in umbilical vein or intravenous. Avoid episiotomy. Receiving continuous care from a midwife during labor. Being closely monitoring during the third stage of labor. Identify people who have the propensity of bleeding, called coagulation defect. If patient have history of postpartum hemorrhage, previous pregnancy, should we know the cause or the risk factor will develop postpartum hemorrhage. Active management of third stage of labor was done to avoid postpartum hemorrhage in this pregnancy. Prophylactic oxytocin reduce the risk of postpartum by 60%. Oxytocin or oxytocin with ergometry. Drugs given to patient in labor room. 5 international units IM for vaginal delivery and 5 international units IV for lower segment cesarean section. Consider oxytocin in infusion. بالإضافة إلى 5 units direct, we can give the patient continuous IV infusion. Another preventing measure for postpartum hemorrhage: correction of anemia during pregnancy or during delivery at labor room will prevent postpartum hemorrhage, and blood loss and shock will develop rapidly if she had anemia. Anticipation that are certain risk factors which are associated with postpartum. Those with previous history of postpartum hemorrhage will develop 2 to 4 times more risk for postpartum hemorrhage than those with no previous history. Active management of the third stage of labor, which combination uterotonic administration, oxytocin and ergometry, and another active management, early cord clamping and cutting, and gentle cord retraction with uterine contraction when the uterus is well contracted. That means brand underway maneuver. For delivery of placenta, not leave the placenta delivered till 30 minutes, but immediately once we initiate the delivery of placenta to avoid postpartum hemorrhage and blood loss. The oxytocin drug includes syntocinon, ergometrin, and symptometrin. 1 ml contain 5 units oxytocin and 0.5 mg ergometrin. We have ampoule of oxytocin اللي هو P2C, either alone only oxytocin, or maybe sometimes we have combination of oxytocin and contain oxytocin and ergometry. The main causes of a traumatic primary postpartum hemorrhage, tone, we briefly by 40, tone, tissue, thrombin, and trauma. Tone due to previous postpartum hemorrhage, loss of contractility of the uterus, prolonged labor, age more than 40 years, because of the uterus is atony, and relax, big baby, lead to big placenta and big uterus, multiple pregnancy, also distension of the uterus, placenta previa, abnormal implantation, and lead to delay contraction of the uterus, obesity, Asian ethnicity, and tissue either retained placenta, always in normal vaginal delivery, cesarean section if the placenta adherent to the uterine scar, membrane or clotting of the uterine bleeding. Thrombin, abruptio of placenta may lead to decreased thrombin clotting factor and lead to coagulation failure, preeclampsia, pyrexia, intrauterine death, amniotic fluid embolism, lead to disseminated intracoagulopathy. Trauma, cesarean section, increased risk of postpartum hemorrhage because we do scarring and patient develop for prolonged period for bleeding from the site of injured scar. Either emergency or elective, both of them will develop postpartum hemorrhage, but with emergency cesarean section more than postpartum hemorrhage. Perineal trauma, operative delivery, vaginal and cervical tear, uterine rupture. Blood loss is commonly underestimated. Loss may be well tolerated. Beware the trickle and the moderate lossure. Minor postpartum can easily progress to major postpartum hemorrhage. So we should not neglect mild postpartum hemorrhage or minor postpartum hemorrhage. This blood loss may lead to major postpartum hemorrhage. Blood loss and sign and symptom of the patient. This table reveals blood loss, blood pressure, sign and symptom. If blood loss 500 to 1000, this blood pressure may be normal or subnormal. Signs on symptom: palpitation, dizziness, tachycardia. If blood loss 1000 to 1500 more, slightly low. Blood pressure started to hypotension. Sign and symptom: weakness, sweating, tachycardia. If blood loss 1500 to 2000, about 3 to 4 units of blood loss, blood pressure become very low. Systolic 80 to 80 millimeter mercury, and diastolic below 60. Restlessness and pallor oliguria. If blood loss 2000 to 3000 mol, that means hypotension more developed, systolic from 5 to 70 millimeter mercury, and patient develop collapse, air hunger, and anuria. If more than 2500 cc blood, maybe the patient will develop shock, and we cannot control to blood loss. Management: has the placenta been delivered and it is complete? If the uterus well contracted, is the bleeding due to trauma? Management according to the cause and risk factor. Management of postpartum hemorrhage. First of all, call for help. We should call midwife, nurse, rotator, permanent, senior on-call. All the staff should be available to do ABC for the patient. Team obstetrician, anesthetic, hematologist, and blood bank. Correction of hypovolemia. A certain origin of bleeding should be diagnosed by the senior. Ensure uterine contraction by giving oxytocin drug. Surgical management if we have tear or ruptured uterus or any surgical cause for postpartum hemorrhage. Management of special situation. ممكن another cause, maybe hematoma, maybe atony, full bladder. This should be evacuated. Uterus if had retained placenta or any other membrane or clothes. Resuscitation, first of all, ABC, airway, breathing, circulation. 10 to 15 liter per minute oxygen by face mask, large bore gauge cannula, blood for complete blood picture, urine analysis, liver function test, clotting factor, cross match for at least 4 units, 2 liter of steroid rapidly supply or transfuse as soon as possible. Consider O negative blood if any delay, because the O negative can give it for all type of ABO blood group. Uterine contraction, first line drug, oxytocin, either IV, intrauterine, or infusion, or IM. Ergometrine, this oxytocin 5 international unit, either given IV or IM, or according to the condition of the patient because of the side effects of oxytocin. First of side effect, hypotension if given directly, and second antidiuretic hormone. Ergometrine 0.5 milligram. Carboprost, hemapate 0.25 milligram IM every 15 minutes in 8 doses. Misoprostol 600 microgram sublingually, or either vaginal or rectal. We can use as a for tonic of uterine contraction. Uterine contraction, another method, non-pharmacological agent. Empty uterus should be evacuated uterus if retained product of conception, either placenta, clot, membrane, or any pathology. Follis catheter for full bladder if full bladder are prevent uterus from contraction. Wrap up a contraction, enhance uterine contraction by massage for the uterus to enhance uterine contraction by manual compression, vaginal and abdominal, balloon tamponade, brace sutures, uterine artery ligation, internal iliac artery ligation, interventional, radiological for thromboembolism, and hysterectomy for emergency postpartum hemorrhage and invasive postpartum hemorrhage. This by manual compression, one hand from the vagina and the second from the abdomen, and we enhance the uterine contraction. Removal of abnormal placenta, relax uterus with halothine, general anesthesia, and subcutaneous terbutaline. This autocolytic prevent because of the uterus is tightly closed and the internal os is closed, and we cannot insert our hand in the uterus cross the cervical opening. So we need to relax the internal os, then uterus to delivery of placenta. Bleeding will increase dramatically with fingertip Identify cleavage of plant between placenta and uterus, if placenta is retained. Keep placenta intact and remove all of the placenta to avoid retained placenta. By this maneuver, we do cleavage between the placenta and uterine wall. This is by manual compression of the uterus. Birth trauma or hematoma. Hematoma less than 3 cm in diameter can be observed expectantly. If large incision and evacuation of clot is necessary, irrigation and ligate bleeding vessels with diffuse oozing perform layer closure to eliminate dead space. Consider prophylactic antibiotic after evacuation of the hematoma. This valvular hematoma outside in the vagina and the vulva of the female, this after delivery of 4 hours of vaginal delivery. This picture reveals the cervical tear and how to repair after normal vaginal delivery. Either this tear or laceration occur due to infection, due to cervical circulation, due to any trauma from the head of the cervix or instrumental delivery. This another type of our management, B-lunge sutures, and this done for the failure of above maneuver. Then we do laparotomy and do sutures from the above and below to enhance the uterine contraction and avoid relaxation of the uterus. Balloon tamponade, this like the Foley's catheter, we put in the this especially for vaginal route for the uterine wall, and we pump either normal saline or air, and this balloon put for 24 hours and enhance pressure of the endometrium layer of the uterus and prevent bleeding from the site of placenta. Another causes of postpartum hemorrhage, clotting or hematological causes. Management of DIC transfuse without delay and involve hematological services as early as possible. Correct coagulopathy lies with consultant hematological use of factor 7 and fibrinogen. Briefly, this management of postpartum hemorrhage by resuscitation, as mentioned previously by slide, according to the cause. First of all, we see if we have active bleeder, if the uterus is relaxed, if there is a vaginal tear, cervical tear, trauma of the vagina, hematoma in the abdomen. We do this in this figure, show briefly what we do for this patient. About the secondary postpartum hemorrhage, by definition from the beginning, is vaginal bleeding that occur after 24 hours till postpartum hemorrhage till perperium after 6 weeks of delivery, either due to infection, retained placenta, thromboplastic disease. Antibiotic should be given. Evacuation of retained product if bleeding was occur or persist or significant amount of tissue retained. Another cause of postpartum hemorrhage, firstly, we mentioned for a traumatic cause of postpartum hemorrhage. Traumatic lesion of genital tract, either for the uterus or cervical or vaginal or the vulva. Rupture of the uterus, one of the causes of traumatic lesion of postpartum hemorrhage. During pregnancy, a weak scar of previous operation in the uterus, and the most dangerous one is that of classical cesarean section, which is the upper part of the segment. Rupture of the lower segment is rare during pregnancy. Other type of scar, such as scar of myomectomy due to uterine fibroid, tubal ligation or tubal reimplantation. Metroplasty or perforation of the uterus due to dilatation and curettage after abortion. Rupture of the uterus during pregnancy may follow direct trauma or blow of the abdomen or perforating wound or gunshot. During labor, obstructed labor may lead to ruptured uterus, manipulations such as internal podal inversion or manual removal of placenta. Forcible dilatation of the cervix that lead to cervical tear and may extend up to the lower segment, and application of forceps before full dilatation of the cervix. Rupture through uterine scar. The patient had history of previous operation and there is a scar in the skin. The pain, if the rupture occurred during pregnancy, the pain may be slight, and this is called silent rupture, or could be strong pain that is wrong attributed to the onset of labor. With complete rupture, the pain becomes more severe, while during labor, the pain is sudden and severe. Sign and symptom of hemorrhagic shock. This is the type of incision of classical cesarean section upper segment, and this is transverse, low transverse, and we have low transverse, lower segment cesarean section, and this is the more common cause of rupture of the uterus. Spontaneous rupture during obstructed labor. There are signs and symptoms of prolonged or obstructed labor, as patient revealed. Violent uterine contraction immediately before the rupture occurs. Sign of cephalopolyp disproportion because of CBD, either big baby, either narrow pelvis, or inefficient uterine contraction. Malposition or malpresentation. Fetal distress. Severe and sharp tearing pain in the lower abdomen. After the rupture has occurred, there are a sign and symptom of shock. There is usually vaginal bleeding, slight or severe vaginal bleeding, and abdominal pain after rupture of the uterus has occurred will be decreased. Another cause of postpartum hemorrhage, traumatic laceration of the cervix, may be caused by the precipitated rapid labor and application of the forceps while the cervix is not fully dilated, rapid delivery of the after coming head, any future presentation, scar in the cervix from previous injury, as we mentioned, due to cervical circulage, عملية رابط عن قرحة, and dilatation and curettage may be aggressive, or any operation, cone biopsy, or any operation done for cervix. The presentation is that of continuous vaginal bleeding during and after the third stage of labor, with continue in spite that the uterus is empty and contracted. The patient should be examined under GA after initial resuscitation with a wide speculum. The anterior and posterior lip of the cervix are healed with a sponge forceps and drawn down. Then the tear is sutured with interrupted catgut or Dixon sutures. As this picture will mention the tear and the cervix. This is the upper or anterior aspect of the cervix, and this is the posterior, and this the tear. If the rupture has occurred, laparotomy should be done, but after initial resuscitation and correction of blood loss. At laparotomy, in case of distant scar, usually the bleeding is slight due to the presence of fibrous tissue, and usually it is possible to excise the edge of the scar fibrous tissue and resuturing it. If the rupture is due to other causes, then the management is by repairing the rupture, and prefer to do bilateral tubal ligation if complete hair family, and prevent subsequent rupture, because in subsequent pregnancy it is a risk factor for liable for distant scar or ruptured scar. If rupture is so extensive that it cannot be repaired, especially lateral side rupture, then subtotal hysterectomy should be done, but it is associated with higher mortality and morbidity than with repair. After the operation, the patient should be received broad-spectrum antibiotic. Thank you for listening, and if any question, send for me on the classroom about any explanation. Thank you.